and gentlemen, welcome to the first academic event of SimCon 2021, the Grand Ward Round 1, Unravel the Mystery. Every day, during medical wards, several medical cases are being discussed in the wards all over the country. Today, during the next 50 to 55 minutes, there will be two cases discussed by two eminent specialist physicians in internal medicine with their medical registrars. May I invite Dr. Deepa Amarasekara and Professor Udaya Ranapanawa, specialist in internal medicine, to come out the stage.
This grand ward round is basically it's a ceremonial expression of what we do every day. Everywhere the internal medicine specialists discuss their cases during the rounds. We are going to do the same thing here. The first case is going to be discussed by Dr. Deepa Amarasekara and is going to be presented by Dr. Saranija, the registrar of Dr. Deepa Amarasekara. Deepa Amarasekara is a specialist in internal medicine and is a consultant physician in charge of a medical ward in North Colombo Teaching Hospital. I'll invite Deepa to start the discussion, and I'll ask Saranija to come and present the case.
Good morning, everyone. In the grand rounds, today I am going to present a case of a middle-aged female with chronic cough. Our patient is a 45 years old housewife from Vattala. The presenting complaint was cough for 3 months duration associated with on and off fever. Our patient was apparently well before 3 months. Our patient was apparently well before 3 months when she developed cough productive of yellowish sputum. There was no chest pain, shortness of breath or hemoptysis. The cough was associated with on and off low-grade fever which responded to paracetamol. The patient took treatment on and off from the GP, but the symptoms didn't completely resolve. This time, the patient got admitted because the fever was high grade and she had difficulty in breathing. She had severe loss of appetite and lost around 8 kilograms during the past 3 months. During the ward stay, 2 days after the admission, patient developed redness in both eyes, but there was no visual impairment, pain or discharge. 4 days after the admission, patient developed small reddish rashes over the tips of the fingers and toes. 5 days after the admission, the patient complained of fullness and tinnitus in the right ear. There was no hearing impairment, discharge or pain from the ears. There was no yellow discoloration of the eyes, abdominal pain or distension. Her bowel habits were normal. There was no urinary symptoms. There was no past history of nasal bleeding, recurrent ear infections, early morning sneezing or wheezing. There was no history of oral ulcers, alopecia, arthralgia, myalgia or photosensitivity rash. There was no history of night sweats or contact history of tuberculosis. There was no history of exposure to radiation. She is a non-smoker and she didn't have any significant exposure to passive smoking as well. There was no exposure to birds or farm environment. Her past medical history, past surgical history, and allergic history were not significant. Apart from the drugs which taken from the GP for symptomatic management, her drug history also was not significant. Her LRMP was 1 week before the admission, and there was a history of T1 miscarriage once. There was no significant family history of connective tissue disorders, vasculitis, hematological or lung malignancies. She is a mother of 3 children and her husband works in a private company. There was no history of sexual promiscuity. She had studied up to A-level and she is a non-alcoholic. She had good family support. In the examination, she was ill on admission and was emaciated with a BMI of 18 kg per meter squared. She was dyspneic, pale, but not icteric. There was no peripheral lymphadenopathy or ankle edema. 2 days after the admission, patient developed redness in both eyes, suggestive of keratoconjunctivitis. 4 days after the admission, patient developed vasculitic rashes over the fingertips and toe tips. In the cardiovascular system examination, the patient had a sinus tachycardia. Though her BP was initially normal, during the ward stay, the blood pressure has increased to 160/90 millimeter mercury. Her heart sounds were normal. There was no murmurs or pericardial rubs. In the respiratory system examination, the saturation was more than 94% throughout the ward stay, and she had lung signs consistent with right upper and middle zone consolidation with associated left lower zone consolidation. In the abdominal examination, she had isolated hepatomegaly. The nervous system examination was normal, and especially the fundi were normal.
Can you summarize the important findings you have gathered from the history and the examination?
Our patient is a 45-year-old housewife. She presented with cough and fever associated with constitutional symptoms for 3 months duration. She was pale and had isolated hepatomegaly and features of right more than left lung consolidation in examination. Her blood pressure was initially normal, but during the ward stay, the blood pressure has increased. She developed bilateral keratoconjunctivitis, vasculitis rash, and fullness of right ear during the hospital stay.
So what are the differential diagnoses you can think of?
So this patient is a 45-year-old female patient with a history of chronic cough and fever with the high prevalence of tuberculosis in our setup. My first differential diagnosis was disseminated tuberculosis. The other infective causes like subacute infective endocarditis with embolic phenomena and acute pneumonia on top of lung malignancy with paraneoplastic vasculitis was also under our differential diagnosis. With the vasculitic rash, fever, and respiratory involvement, we thought of ANCA-associated vasculitis and non-ANCA-associated vasculitis like connective tissue disorders, and cryoglobulinemia also was one of our differential diagnoses.
So how did you proceed with the investigation? Tell me the basic investigation first.
In the basic investigations, in the full blood count and blood picture, there was evidence of neutrophil leukocytosis with microcytic hypochromic anemia suggestive of iron deficiency. Her inflammatory markers were elevated. Her serum electrolytes were normal. Her serum creatinine and blood urea were under normal limits. In the UFR, there was microscopic hematuria with proteinuria. Her dysmorphic RBCs were negative. In the urine protein quantification, she had subnephrotic range proteinuria. The urine, blood, and sputum cultures were all negative. In the liver function test, there was mildly increased transaminases with increased ALP and gamma GT suggestive of infiltrative type of liver injury.
What are the radiological investigation you have?
In the X-ray, there was features suggestive of right upper and middle zone consolidation with left lower zone consolidation. We went ahead with the CECT chest. There was a large area of consolidation in the right upper lobe, and there was a left lingual lobe consolidation also.
How did you exclude the infections and the malignancy?
We have excluded malignancy with the CECT chest, and we went ahead with the bronchoscopy to see any malignancy as well as stenosis. So the bronchoscopy was normal. Bronchoalveolar lavage fluid was suggestive of infection, and the TB gene expert and cytology were negative. We excluded TB with the negative sputum AFB, sputum TB gene expert, and MAN2. In the ECG, there was sinus tachycardia, and with the transthoracic echocardiogram and transesophageal echocardiogram, we have excluded infective endocarditis as well. In the ultrasound scan abdomen, there was a prominent spleen with hepatosplenomegaly and evidence of acute kidney injury.
So basically, we have excluded the infections and the malignancy in this patient. So what are the investigations you have done for identification of small vessel vasculitis?
We did the ANCA levels. The C ANCA was positive.
And any other investigations to rule out non-ANCA associated vasculitis?
We did ANA and dsDNA. Both were negative with negative C3, C4 levels. So we have excluded SLE. And we did a hepatitis C antibody and cryoglobulin. Both were negative. So the cryoglobulinemia also was excluded. The hepatitis B surface antigen, which also can create similar picture, also was negative.
What are the histological examination you got from this patient?
So during the ward stay, the patient has rapidly developed the vasculitic rash, and in the UFR also there was evidence of microscopic hematuria was proteinuria with elevated blood pressure levels. So we went ahead with the skin biopsy and the renal biopsy. In the skin biopsy, that was suggestive of lymphocytic vasculitis, and the renal biopsy, there was evidence of necrotizing glomerulonephritis with crescent formation, which was suggestive of small vessel vasculitis or lupus nephritis. We did the immunofluorescence studies also. There was mild immunoglobulin staining with negative C3 staining, which was also suggestive of post-immune glomerulonephritis, which is seen in small vessel vasculitis.
So after the history, examination, and the investigation, what is your final diagnosis?
With the history, examination and investigations, our final diagnosis was granulomatosis with polyangiitis, which is formally known as Wegener's granulomatosis, with ophthalmic, upper and lower respiratory tract, renal and cutaneous involvement.
How did you manage this patient?
So on admission, the patient was very ill and she was having fever spikes. So after taking the cultures, we have started the patient on IV ceftriaxone and clarithromycin, but the patient didn't clinically improve with the antibiotics. The anemia was managed with blood transfusions, and the blood pressure also was controlled with antihypertensives. During the ward stay, the patient has rapidly developed the other systemic manifestations, following which we have taken the rheumatology opinion, and they have suggested to start on IV methylprednisolone. We have liaised with the nephrology team and the dermatology team, and the biopsies were taken before starting the immunosuppressive. Pending results, we have started the patient on IV methylprednisolone and followed by oral prednisolone, for which the patient has responded. Meanwhile, we have done an ENT referral, and there was right side otitis media. When the biopsy reports were available and there was a diagnosis of Wegener's granulomatosis, we have started the patient on IV cyclophosphamide pulses, And with that, the patient has clinically improved and she was discharged with oral prednisolone, valganciclovir, and Cotrim prophylaxis. The second dose of CPP also planned after discharge.
Good. So, a few words about the small vessel vasculitis. The small vessel vasculitis should be suspected in any patient who presented with multisystem involvement. If it is not caused by infection or malignancy. The constitutional symptoms are very common in small vessel vasculitis. The other clinical manifestation may vary depending on the organ involvement. So the diagnosis may be very challenging. To determine which type of vasculitis is met in a given patient requires knowledgeable integration of clinical findings, laboratory finding, both positive as well as negatives, and the pathological examination of involved organ. In our case, the patient was diagnosed to have ANCA-associated vasculitis. So the ANCA-associated vasculitis is the most common primary systemic vasculitis in adult. It has three categories: granulomatosis with polyangiitis, GPA, formerly known as Wegener's granulomatosis, and the second one is a microscopic polyangiitis, and the third one, the eosinophilic granulomatosis with polyangiitis, EGPA, formerly known as Church-Strauch syndrome. The granulomatous polyangiitis can be differentiated from the other two categories in the presence of necrotizing granulomatous inflammation and the absence of bronchial asthma. Eosinophilic granulomatous polyangiitis can be differentiated from the other two conditions in the presence of asthma, eosinophilia, and the necrotizing granulomatous inflammation in the involved organ. Whereas in MPA, the microscopic polyangiitis can be differentiated from the other two conditions in the absence of asthma and the absence of granulomatous inflammation in the tissue involved. Usually it has a necrotizing inflammation. Our patient had a clinical spectrum with upper, lower respiratory tract involvement, renal, ophthalmological, and skin involvement with the evidence of rapid progression. So both granulomatous polyangiitis as well as a microscopic polyangiitis can cause life-threatening pulmonary and renal involvement, and the treatment in both conditions essentially the same. So we started the treatment without waiting for differentiation. So we had to liaise with the other subspecialties timely and effectively to arrive at a diagnosis without any delay. Here, as an internal medical specialty, we played a critically important role for rapid diagnosis because the life-threatening injury to the organ often develops quickly, and it is mitigated dramatically by the immunosuppressive treatment. Thank you.
We have some time to ask questions. About 5 minutes. May I ask one question, Deepa? Did you do procalcitonin before starting methylprednisolone in this patient? Right, okay.
I have two questions. One thing is, when at any time did this patient have a rising creatinine?
No.
No, never.
It's unusual to have a necrotizing glomerulonephritis with crescents with the normal renal functions. So I think you should keep an eye on his creatinine. Second thing, he has an enlarged liver and a raised alkaline phosphatase. How can we explain that?
So usually small vessel vasculitis can involve, they can involve arterioles, capillaries and veins, sometimes small arteries and veins as well. So it can cause organ involvement as well. So infiltrative type of organ involvement can be.
You all didn't plan for a liver biopsy at
No.
in some stage? Did you do a blood picture? He has significant anemia for 6
Yeah,
point something.
because she has a constitutional symptoms for about 3 months with severe loss of appetite and loss of weight. And we did anemia was on admission. She was HB is around 6.5, and we transfused with blood transfusion. Stool for Albert was negative, and so we didn't
Probably
proceed.
anemia associated with the chronic disease
Usually,
process.
the small vessel vasculitis can affect the GIT tract as well, but here, of course, this patient did not
Didn't
have
have any
any
bleeding.
bleeding manifestation.
Are there any more questions from the audience?
Multi-systemic disease which involves like various system, which it looks like an inflammatory disease. Like when you consider that, like, have you ever thought of sarcoidosis? Because that can also have the sort of like similar presentations.
Actually, we did the serum calcium levels, that was normal, and the chest X-ray didn't reveal any high lymphadenopathy. And because of those two conditions, and at the same time, we got the ANCA positivity, and so we proceed with the other small vessel vascular investigations.
Okay, thank you.
Thank you very much, Dr. Deepa Amarasekara and Dr. Saranija, for that excellent case discussion. Shall we move to the next case presentation? This will be done by Professor Uday Ralapanava and with the registrar, Dr. Diniti Rupasinghe. Professor Uday Ralapanava, MBBS Pera, MD Colombo, MRCP UK, FRCP London, FRCP Edinburgh, and FCCP. Professor Ralapanava is a professor in medicine and a consultant physician at the Teaching Hospital Peradeniya, and the current head of the Department of Medicine, Faculty of Medicine, University of Peradeniya. And Dr. Diniti Rupasinghe will be present in the case, and Professor Ralapanava will be discussing the case.
Good morning, everyone. Today, we are going to present a case about a young boy who has presented with non-specific ill health, which has been a challenge for the diagnosis and management. So he has been a 19-year-old, previously healthy male from North Central Province who has admitted with abdominal pain for 4 months with loss of appetite and loss of weight, and fever for 2 months and bleeding from mouth. So this abdominal pain was very frequent and was persistent throughout the day, which mainly confined to the epigastric region and was burning in type, and it does not relate with change in posture, and it was not associated either meals or vomiting. So furthermore, he did not have any yellowish discoloration of eyes, pale stools, or alteration of bowel habits. His weight loss was more subjective, that is partly due to the poor oral intake with recurrent abdominal pain, and he denied any history of substance abuse, and no significant past medical, he did not have any significant past medical history, and he has been functionally independent since he has been running his own business since the age of 16 years, and he has had a good family support as well. In admission to the Peradeniya, the patient had fever for 2 months duration, which was low grade, and it did not associated with either chills or rigors, and it was not relieved with simple analgesics. So furthermore, he did not have any skin rashes, altered bladder bowel habits, chronic cough, or arthralgia or myalgia. And he denied any postural symptoms, or there was no any skin pigmentation, and he had bleeding manifestations from no other bleeding manifestations except from mouth bleeding, and there was no pruritus as well. Prior to the admission to the teaching hospital Peradeniya, for the last 3 weeks, he has had bilateral lower limb swelling and periorbital swelling. So this lower limb swelling was persisting throughout the day, whereas the periorbital swelling was initially intermittent and later on it persistent throughout the day. And he denied any proteinuria or shortness of breath, and there was no associated hypo or hyperthyroid symptoms. And furthermore, he has denied any history of TB contact and traveling to any malaria endemic areas or recent foreign travel, or denied high-risk sexual behaviors as well. If we move on to the examination of the patient, initially he was cachectic with a BMI of 17.8 kilograms per square meter, and he was alert but not oriented, and afebrile, moderately pale, and he had a hemorrhagic oral mucosa with difficulty in mouth opening, no neck stiffness or focal neurological signs, and he has had inguinal lymphadenopathy, which is more than 1 centimeter, firm, discrete, and multiple, and he has had bilateral pitting ankle edema, and his abdomen, cardiovascular, and respiratory system examination was unremarkable, and there was no vasculitic or other skin rashes. So in this image, it shows the initially ill-looking, moribund patient who has been physically restrained and as well as is bedbound, and he is on an NG tube for his feeding. And the second image, it shows the unhealthy oral mucosa with evidence of mucositis. And here's the bilateral pitting type ankle edema.
Right. Now you have seen the patient and examined the patient. So initially, what was your working diagnosis?
So initially I was thinking about the hematological malignancies like leukemia or lymphoma, because it's a 19-year-old boy who has been presenting with constitutional symptoms and fever along with lymphadenopathy. And then secondly, mainly the chronic infections like tuberculosis and HIV, even though the history is not that suggestive, but there can coexist as well. And those are my first differential diagnosis with the given history and the examination of the patient.
Now you mentioned about leukemia. Why did you think about the leukemia?
Because it's a young male who has been presenting with these constitutional symptoms and fever, and along with lymphadenopathy. So that's why I was thinking initially with the leukemia and the lymphomas.
So when you consider the oral mouth, the mouth hygiene or any evidence to support your diagnosis of leukemia?
So I was thinking whether it is myelomonocytic leukemia can be a differential diagnosis in this case.
Okay. So then how are you going to investigate this patient?
Initially, I would like to proceed with the basic investigations, whereas his full blood count revealed WBC of 2,600 with severe lymphopenia, and his hemoglobin was 9.5, and the platelet was 59. And the blood picture, which showed pancytopenia, which needs further evaluation, and his ESR was 21, and CRP was less than 6, and the clotting profile was normal, and he had a marginally elevated retic count along with an LDH levels. And since he has had this recurrent abdominal pain, the serum amylase level was normal, but chest X-ray and the abdominal X-ray was also did not relieve any abnormal findings. The liver functions, it was normal except for the hypoalbuminemia, and the urine full report, there was no dysmorphic cells, but he has had significant proteinuria, and the serum creatinine was 76 micromoles per liter, which was marginally high for his age, and the ultrasound scan abdomen with KUB was a normal study.
So now this patient you noted there as a pancytopenia. What are the possibilities of pancytopenia in this patient?
When considering about the pancytopenia, we can categorize it into either the causes, which can central causes and the peripheral causes. The central causes can be further categorized into due to bone marrow suppression or the maturation defects. The condition which can give rise to bone marrow suppression could be aplastic anemia and bone marrow infiltration, acute leukemia, miliary tuberculosis, myelofibrosis, and paroxysmal nocturnal hemoglobinuria. And in addition, the maturation defects would be myelodysplastic syndrome and megaloblastic anemia and hemophagocytic syndrome. If you move on to the peripheral causes, it can be due to increased destruction secondary to the hypersplenism or SLE and other autoimmune conditions, and the sequestration could be secondary to splenomegaly.
Now you have some investigation findings. Now to confirm the diagnosis, what further investigation you would like to do?
So since he has had this pancytopenia and lymphadenopathy as well, I would like to go ahead with a bone marrow biopsy and hepatitis B, C, and parvovirus studies, and lymph node biopsy, and as well as HIV serology. Whereas his HIV serology and hepatitis B, C, and parvovirus studies came as negative, and the lymph node biopsy, it relieved reactive lymphadenopathy. But surprisingly, the thing was the patient, while waiting for the bone marrow biopsy, he developed recurrent episodes of seizures. And sometimes it is like partial seizures, and then later on it was complex partial and absent seizures. And during these in-between seizures, the patient was much more aggressive, and he started hallucinating as well. It included both visual and auditory hallucinations as well.
So now with this new development, do you want to consider new differential diagnosis, or would you like to consider same differential diagnosis?
Yes, sir. But still I would like to keep my first differential diagnosis, like these hematological malignancies and the chronic infections. But along with that, because of this, with the investigation, he has had a significant pancytopenia. So I would like to consider this macrophage activation syndrome along with autoimmunity. And with that also, with considering the autoimmune conditions, I would like to consider systemic lupus erythematosus as well on this patient. So since I have had new differential diagnosis with the new development of the symptoms of this patient, the history and the examination has been revisited. So on direct inquiry, patient had admitted to have non-scarring alopecia for 6 months duration. That was about 2 to 3 months prior to the onset of rest of the symptoms. And with the revisiting of the history and the the chronology of events would be, he has had non-scarring alopecia initially, and then later on unhealthy gums, and then the abdominal pain, fever, and recent onset seizures.
So then what additional investigation you would like to do for this patient?
Since with the new development of seizures, I would like to go ahead with the EEG. So on this patient, the EEG showed that there was seizure activity and no evidence of encephalitis. And the non-control CT of the brain, it was a normal study. And the MRI brain, it revealed small vessel disease. And his APLS screening was negative. And the bone marrow biopsy we have proceeded, and it showed early bone marrow hypoplasia. And the fibrinogen and the triglyceride levels were normal. An ultrasound scan of the abdomen did not relieve any organomegaly. And since he has had significant proteinuria in the very beginning, we proceeded with the urinary protein creatinine ratio, which revealed a nephrotic range proteinuria. And as well as we did an ANA, which came as positive. It's more than 1 into 640 with a homogeneous nuclear pattern. And the complement levels, C3, C4, they were both were extremely low, whereas the C3 levels were undetectable.
Right. Now you have enough investigation findings. So what is your final diagnosis?
So I would like to consider SLE with cerebral, hematological, mucocutaneous, and possible renal involvement as my final diagnosis.
So how did you manage this patient in your ward?
It has been a multidisciplinary approach. Team involvement we took early in the course because it's an emergency and we didn't have any time to lose. And so the management options would be the controlling of seizures and the modifying disease activity and the supportive care, whereas the supportive care included airway management, pressure point care, bladder bowel care, nutrition, and DVT prophylaxis. And for the management of seizures, initially we started off with oral anti-epileptics, but he was not responding with the oral anti-epileptics and he continued to have recurrent fits, so we had to load him with IV anti-epileptics. But would say the ultimate treatment in seizures of this patient would be the disease activity modification. And secondly, modifying the disease activity is the next step of management. So we started the treatment with the high clinical suspicion with a pending ANA report since we didn't have any time to lose. So we induced remission with the IV methylprednisolone pulse therapy. And then we went ahead with IV cyclophosphamide pulses. Even though there are several dose regimens existed, we started him with 500 milligram dose regimen every 2 weekly for a total of 6 pulses. And then the maintenance therapy was initiated with MMF and oral steroids. So here it shows the EULA criterion for the classification of SLE in, which came out in 2019. In here, what they say is the patient must have at least more than 10 points to be classified as SLE, but whereas our patient fulfilled about more than 20 points in the classification criteria of SLE. So I must say it has been a success story where you can see the patient before starting the treatment. It's a ill-looking patient who has been physically restrained and with an NG tube. And here is the patient after 2 months who is coming for his cyclophosphamide pulses every fortnightly with a happy smile on his face. And finally, a few words about cerebral lupus, since it has been a success story. Main symptoms of cerebral lupus can be either diffuse or focal, whereas the diffuse symptoms, they come with either generalized seizures or psychosis or sometimes with headache. And the focal symptoms, they might get strokes or peripheral neuropathies. But these neuropsychiatric symptoms, it's a very rare presenting symptoms of the SLE. And if they present, they will present within the first year of the SLE. And approximately about 40% of patients with SLE, they will have CNS manifestations. And if they get the CNS manifestations, they will place the patient in the severe end of the spectrum of this disease. And early involvement of a multidisciplinary team will improve the outcome of the patients, like in our patient who responded very well with the treatment. And so, thank you.
So as Diniti mentioned, this is the example of vigilant diagnosis by the internal medicine physicians, and then involvement of multidisciplinary approach, and ultimately the benefit for the patient, and patient is now coming to clinic and he improved markedly. Thank you very much.
Thank you very much, Professor Alapanava and Dr. Diniti Rupasinghe, for that very interesting case. Actually, a male SLE patient actually presented an unusual way and is found to be a lupus, cerebral lupus as well. Are there any questions from the team?
Did you all do a lumbar puncture?
Lumbar puncture, so we did it.
So normal.
Normal.
Because initial presentation of SLE as cerebral lupus is very rare. Usually about
Agree.
15%
Yes,
of patients.
it's a very rare entity, yes.
Or you would always exclude an infection or a drug-related causes before labeling them. Did you all do a ribosomal P antibodies? Because
No, we didn't do.
ongoing abdominal pain as well, so to rule out abdominal SLE and it will support the diagnosis of
No,
cerebral
we
lupus
didn't
as
do,
well.
right.
May I ask a question from
Yes,
Professor Alapanava? Did you have treated with cyclophosphamide and the
Yes.
mycophenolate mofetil?
Yes.
Is there any advantage of using mycophenolate mofetil in this patient?
Yeah,
As a
for
continuous-
the maintenance therapy, we use the MMF, and in the azothioprine is other option. right? But you know, the MMF, the evidence for the cerebral lupus treatment, the evidence for the MMF is more than the azathioprine. So we use the azathioprine, MMF as the drug of choice for the maintenance therapy.
Are there any other treatment which can be given for these kind of patients?
To the maintenance or
As a
induction?
maintenance?
In,
Induction also, yeah, there are drugs like rituximab. Is there any place?
Yes, rituximab can be used, but problem is rituximab can cause severe and profound immunosuppression, which can last for even 6-month period. So if we'll say the rituximab is not working, then difficult to change to the other type of immunosuppression. Other thing, now this is a COVID era, so they have shown the high mortality in a patient using the rituximab. So because of that, we go ahead with the cyclophosphamide, and patient responded very well for the cyclophosphamide.
Any other questions from the audience?
Reason for the main complaint, the abdominal pain?
So we thought that it could be the serositis which is causing this recurrent abdominal pain.
Serositis, where? The peritoneal region?
Yes, yes.
Were you able to sort of demonstrate this cerebral lupus, diagnosis of cerebral lupus? How did you make the diagnosis?
Along with the presentation, sir, because he has had this generalized fits and then psychosis, and also while we have with the other clinical classification criterion, because we had a high clinical suspicion of that, and because history has been revisited, so because he has had this alopecia, and then along with the abdominal pain, we were thinking whether it is serositis, and then other pancytopenia, the classification criteria mainly involving the renal, and as well as that because of that we had a high clinical suspicion of cerebral involvement.
Was there any place for this autoantibodies of autoimmune encephalitis kind of thing, Professor Alapanav? Was that important?
That's a good thinking, but now this patient, now he is fulfilling I think the more than enough criteria to make a diagnosis SLE. And with that, he is having clear evidence of cerebral involvement, so which is demonstrated in even this new criteria of the diagnosis of SLE. And we did the LP also, it came as a negative and no evidence of infection, right? So then I think the most of the things are in favor of diagnosis of SLE and cerebral lupus. So that's why we came to the diagnosis of SLE lupus. MRI was done. MRI is done, but it didn't show any changes. Only the small vessel vasculitis.
Vasculitis.
Yes.
I thought like, I don't know, the MRI scan itself like can suggest like this is cerebral involvement.
Yes, sometimes you can get a T2 weighted imaging, you can get a hyperdense area, hyperintensity area. But our patient, it was not there. The comment was small vessel vasculitis.
Okay.
How common is this male cerebral lupus? And
according
is
to
there any association between, will there be any association with any other syndrome? Also, did you do a double-strand DNA antibody?
Double S DNA was done. I think that report I didn't see.
Positive.
Sorry?
Positive.
Positive. It is positive. And the answer to the first question, it is a very, very rare entity. You know, even the cerebral lupus is very rare, and the male patient present with the cerebral lupus is very rare. So percentage-wise, I don't know, but it is the literature says it's very rare.
Any other questions from the audience? In the absence of any questions, shall we conclude the session? And this grand ward round, there are two cases we have discussed today. The first case, actually female, 45 years, presented with a lung consolidation and found to be ultimately the GPA, granulomatous polyangiitis. And the second case, a young male patient presented in an unusual way and again ultimately diagnosed with cerebral lupus. So I will thank the both team, Dr. Deepa Amarasekara and her registrar, and Professor Uday Ralapanava and his registrar. And I will invite my co-chair, Dr. Harindra Karunatilakata, to hand over the certificates to the consultants and the registrars, the both team. Dr. Deepa Amarasekara. Professor Uday Ralapanava. Dr. Saranija. Dr. Diniti Rupasinghe. That will conclude the grand ward round. Thank you very much.